Majin, and we're going to be doing surgery today and broadcasting live to you to watch. The surgery we're doing is a Deuk laser disc repair at L3-4 and L4-5. Our patient has two problems. He has a degenerated disc at L4-5 and he has a herniated disc at L3-4, and he's having back pain and left leg pain. So we need to see more of the back, less of the front. So if you want to drop the table a little bit. Jordan, will you talk to the anesthesiologist and make it right, please? All right, so the patient, you can see on the x-ray, clearly has metal and a fusion. And the fusion was done before I got to him. It was done by somebody else. Who did your fusion on your back? El Comos. Yeah. Okay. All right. All right. So he had a fusion done by an orthopedic surgeon, I should say, locally. And you could see the screws and rods at L5-S1. He has adjacent segment disease, which is basically the disc above the fusion is really bad, L4-5. It's totally collapsed, sclerotic, spondylitic, and totally inflamed. Just giving you a little numbing medicine, okay? To make it more comfortable. You can see how collapsed the L4-5 disc is. So people say, is the Deuk laser disc repair good for degenerated discs? Absolutely. It works really well for degenerated discs. Shot? Now this is going to be a really difficult one to get into. And I may have to come in a little bit lower. Huh?
Yeah, I was thinking the same thing.
Let's go for some more numbing medicine. So this patient suffered with back and left leg pain for a while. How long have you had your back and leg pain, sir? 10 years. So he's been suffering for 10 years, and he did not want another fusion. He recognized that fusions are extremely invasive. So he decided to come to Deuk Spine to get the endoscopic surgery. And hopefully we'll be able to get that done today. I'm encountering a lot of scar tissue, which is normal after a fusion like this. I just have to work to get around it. And that's why I'm going to keep changing my trajectory until I'm happy with the direction that I'm heading. A lot of bone spur. Yeah, I can feel a fusion mass. I may have to come in a little higher. Well, the reason we broadcast our surgeries live is so that people can watch them and learn from them. Shot? Yeah. And ask questions. All right. Shot? Unfortunately, he has a lot of bone mass here off to the side. So I'm going to have to take a more northerly approach. Shot? That's not ideal. Can we get his blood pressure down? Shot? But the old surgery is forcing me to come from a more northerly approach. Shot? Shot? Let's see where we are there. Hopefully we're not too lateral, but I think we're going to be too lateral. Yeah, too lateral. All right, well, at least we have a direction to work. Let's get some more numbing medicine. Is that where we are right now?
Yes,
I'm going to give you some more numbing medicine to make it more comfortable. So, one thing that this MRI that we have of him is about a year old. So we ended up doing a new CAT scan, and that CAT scan ended up showing another herniation at L3-4. Shot? So that's why we're doing L3-4 today. You won't see the herniation on the MRI necessarily. There's a bulge there. But you really need the CAT scan to see it. Shot? 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 This is the hardest part of the surgery, is just this first part right here. Just getting to the disc that needs to be gotten to. Shot? Yeah. Where do you feel that?
Left leg?
Shot? Shot? AP? You can see there's a mass of bone just in front of my needle. That is the fusion mass. That's what's going to make it really difficult to get in here. That's what his prior surgeon created, was that fusion mass. All right, let's go back to a lateral view. So I'm going to have to sneak in to the disc at L4-5 just above the fusion mass. That's what I'm aiming for. Shot? Shot? You can feel the fusion mass right there. Shot? Shot? Let's get an AP. So we're in the foramen at this point, getting close to the back of the disc, the L4-5 disc. You can see how collapsed the disc is. It's collapsed about 80%. So there's only 20% of the disc height left. A lot of people worry about that, but they don't need to. Go back to a lateral. It's not the bone on bone that causes pain. It's really a misinformation or mistruth that it's bone on bone that causes pain. It's actually a tear in the back of the disc that causes all the back pain, not bone on bone. I was taught the same thing. Is that okay?
Yes.
All right, so we're just at the bottom of that herniation. Shot? Yeah. So let's see if I can do any better than that. Where do you feel it, Sean? Huh?
Where you're working.
Yeah. Not down your leg.
I said no.
Yep. So we're right at the back of that disc there. I am not going to get in at this angle, but this is the angle I need. So what I'm going to do is get an AP. I'm going to plant the needle here, and I'm going to bring my dilator down, and then I can redirect it right into that disc. I may try one more time to reposition it, try to get a little bit better. Any way you can show me the lateral view there, or show me a little more where the needle is? So you can see the screws and rods that were placed by the other surgeon. Other way. You can see a cage at L5-S1, and the L5-S1 is just solidly fused. Yeah, let's see where we are. A little more rotation, a little more oblique. Yeah, there it is. So we're just on the lateral aspect of the disc. All right, let's go back to the true lateral. So we're really close to where we need to be. Any questions from our audience?
Yeah, yes, we have a question from Sujoy on YouTube.
Hi, Sujoy.
And they ask, Sir, how do you decide the point and depth of
John.
needle entry? Please elaborate it.
Yeah, the point of entry takes experience, knowing where to go, and you basically using the bony landmarks of the spine. It's called navigation. And it's a skill. It takes training, it takes experience. There's no book that describes it exactly because everybody's spine is different. As you can see, this spine right here, I've never seen exactly the same spine. So because of the slippage of the bone, the collapsing of the bone, the screws and rods, the bone formation in the over the facets. Where do you feel that? Just in the back?
In the back of the leg. Back, not the leg.
Uh-huh. I just want to try to get a little bit more north. Shot? So it's just lots of experience, but you know, there's an area that you typically would start, shot, and that's where I'm starting. And then from there you have to do some modifications. And I use a needle that's steerable. Shot? A needle that's able to be directed. Anything there? Any discomfort there? Where?
Yeah, right at the site where you're working.
Uh-huh. Yeah. I'm just not able to get it because of the bone. Not able to get it higher. Shot? That's the best I can do right there. That's good enough. I'm not going to be able to do a discogram with that, but all right. So that's 4-5. Very collapsed, a little bit of retrolisthesis, slippage backwards. The problem is just laterally there's a lot of bone spur formation. And that bone spur or bone formation is from his prior fusion that was done by the other surgeon. So how long ago was your fusion done?
15 years ago.
15 years ago. You can imagine trying to get those screws and rods out would be very difficult. All right, once again, L3-4, we have an MRI picture up, but that's almost a year-old MRI. Actually, I think it's pretty close to a year old. And that MRI that you're seeing doesn't show the herniation that's at 3-4 that we're going after now. You can kind of see a bulge there, but you really don't see a herniation. And now the CAT scan he had done just yesterday. That CAT scan was yesterday, correct? Yeah. Friday. So he just had a CAT scan done, and sure enough, there's a herniation at 3-4, which is what we're going after right now. Shot? 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 Let's get an AP. So we're right where the herniation is at 3-4 on the left side. It's looking pretty good. I may want to try to come a little bit more medial. That's what I'm going to work on. Now this part of the surgery is called navigation. And the part where we use the x-ray to figure out which discs we're treating, you know, where are they located, that's localization. Shot? So we're doing, with this machine, localization and navigation. And navigation and localization with intraoperative fluoroscopy are pretty standard in spine surgery. There's nothing unique about what we're doing with the x-ray machine. But what I can tell you is that we have a top-of-the-line machine. And how are you feeling?
How are you doing, my friend? He said, good.
All right. We're going to put you to sleep soon, okay?
Just said thumbs up.
He's happy about that. All right. So we're in at 3-4. 3-4 was not a problem, but you could see the 4-5 below the tip of the needle is just outside the disc, but it's being forced down by the tissues around the herniated disc in the back at L4-5, the spondylitic tissue. It's like a lot of calcified inflammatory tissue just pushing it down. So I'm going to use a technique when he's asleep to try to navigate into there. Are you comfy?
Doing okay? Say yes. Thumbs up.
All right. So remember, L5-S1 is fused. That's what you're seeing on the X-ray. That's the L5-S1 disc. Then the next disc above is the L4-5, which is totally collapsed. It's 80% collapsed, 80% degenerated. And that's L4-5. That's definitely a problem for him. You can see on the MRI how bad it is, so we want to fix that. And then the next disc up is pretty good, actually. It's L3-4 in terms of its structure. But there is a tear on the left and a herniation, which you could see on the CAT scan. So it's also reported on the CAT scan. So that was done just a few days ago compared to the MRI done a year ago. All right. Now I like to confirm that the discs are indeed the source of pain. We do that with something called an evocative discogram. I can't do that at 4-5 because I'm not in the disc. Are you comfy?
Neil says yes.
All right. Shot? Oh, that's right. We don't have the dye. Okay. All right. All right. Well, let's just put him to sleep. Yeah. I want you to count from 1 to 100 out loud. Now, the 3-4 herniation is not a big herniation, so we're going to start with that one. And then we're going to deal with the L4-5 when he's a little more asleep, because that's going to take some finessing. I like to always get my needle inside the disc through the tear and the herniation to get started. I can't do that at L4-5 because of all the fusion and scar tissue and the bone that the surgeon put in there for the fusion. So I have to basically get my tool as close as I can to that disc, the back of the disc at 4-5, and then kind of leverage it in, manipulate it in. So we'll see if we can get that done. But we'll start with 3-4. How's blood pressure? Can you get it down a little bit? Yeah. So his blood pressure is actually normal, but we like to have it lower than normal for surgery. And a lot of spine surgeons don't pay any attention to patients' blood pressure. They let the anesthesiologist do it. But the reality is the anesthesiologists typically like to keep the blood pressure high. Well, high blood pressure is great for perfusing the heart, the brain, the kidneys, the organs, but it's bad for bleeding, so it causes bleeding. So what you want to do is you want to find a balance between good perfusion, getting all the organs circulation and blood and oxygen and sugar so that they don't have a problem during the surgery, but at the same time you want to minimize the amount of bleeding. So a blood pressure I usually shoot for in a patient that doesn't have heart disease is around 100 systolic. And we put the numbing medicine right into the discogram stuff.
Yes.
Yeah. Shot. Yeah, it's going in pretty easy, so there's definitely a tear. Shot, and he doesn't like it. So that's definitely a source of pain for him. Just relax, you're doing fine. Yeah, I could feel the tear. All right, so we are, and I know that looks brutal, but that's the safest way to get this thing in there. We are now inside the L3-4 disc through a left transforaminal approach. We're just underneath the exiting nerve root. So the exiting nerve root is the L3 nerve root. The traversing nerve root is the L4 nerve root. Just relax, you're doing fine, you're doing a great job. So we're going to put him to sleep a little bit more and get him more comfortable. So I'm going to do this disc first. This is, by the way, the tube the whole surgery is done through, is this endoscopic tube. It's 7 millimeters. It's about, almost a quarter to a half of an inch wide. It's really, really narrow. And it's an endoscopic tubular retractor. So we use tubular retractors in surgery. They're just retractors that are in the shape of a tube. And they hold the tissues apart so we can do surgery. Let me know when you're ready. So my anesthesiologist is getting our patient to sleep, and there's no set amount of drug that puts each patient to sleep. You have to adjust it based on many factors, including their body weight and their sleep apnea, if they have it, or their liver functions and other medications that could be on board. We were talking about this last surgery. Patients that use THC or narcotics or benzodiazepines, they have even alcohol will affect how much anesthetic agent they need to get comfortable. But you don't want to give them too much, because then they stop breathing. The patient will literally stop breathing, and that's bad. So we have to really find a balance for each patient, the right amount. And there's no two patients that are the same. And we've given what we can in terms of numbing medicine. So we're inside the tear, the annular tear and herniation now at L3-4. We're literally inside that disc. And I'm going to take the dilator out at this point. And we're going to leave the tube in. And the whole surgery will be done through this endoscopic tube. So, yeah, that's right there. Now this shouldn't be that bad of a herniation, but once again, we only had a CAT scan view of it. CAT scans don't show disc herniations that well, but you could see it on the CAT scan. And the radiologist picked up on it as well. That's why we decided to do it today. Patient wanted it done. He doesn't want to come back for another surgery. He's hoping this is it. So, what is the reason that a herniated disc causes back pain and neck pain if it's in your neck? Can you run a video that shows our audience why herniated discs cause back pain? It's really due to inflammation going on inside the disc. Meanwhile, we'll get started with our Deuk laser disc repair.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, Submit your MRI for a free review at www.mri.deukspine.com.
All that blue stuff is part of the herniation. I'm grabbing it and taking out little pieces. Unfortunately, it's not one big herniation. It's like a lot of little pieces. A lot of this blue stuff is all herniated nucleus pulposus. So the grabbers are not very effective. That's why we use the laser. For endoscopic surgery, grabbers are not really good, even though that's what most endoscopic surgeons use. They're just terrible, to be honest. And that's probably why they don't use the laser. That's why they don't get such good results like we do at Deuk Spine Institute with the Deuk laser disc repair. The Deuk laser disc repair has been performed now 16 years. It's been peer-reviewed and published in the National Library of Medicine and Surgical Neurology International. Is there an issue with our irrigation? How are we doing on irrigation, ladies? Yeah, okay. I'm just getting a lot of bubbles, so that's usually an indication there's a problem. We're getting close to the end of the irrigation. It's good? All right. Are we using the pump, Luis? And we got a new pump, right? We got another one. We should have like, what, 4 of them?
Oh, no, we have 5.
5? All right, good. So, okay. So the Deuk laser disc repair, what makes this procedure unique is what I'm doing right now with the laser. And this is the key to success. There's a lot of surgeons who badmouth lasers, but the reality is they're badmouthing it for no reason. They just don't do it. They don't know how to do it. That's like, honestly, it's kind of like bad-mouthing something that you have no clue how it works, why it works. It's just eating into your business, so you're going to bad-mouth it. Prejudice, yeah. It's bias, prejudice. I have to admit that I was one of them at one point, because I learned this technique 17 years ago. And before that, I've been a neurosurgeon 26 years. Before that, I was taught by my teachers that the laser was a joke. But then we started using it in surgery. And one of our attendings, Dr. Pincus, started using it in pediatric cases with kids because it's so precise. And then it's like everybody kind of shut up and stopped laughing about it. But there are companies that will manipulate you, the consumer, and try to tell you laser spine surgery when they don't actually use a laser. For example, Laser Spine Institute. I have surgeon friends who work there, and they said they never used the laser, even though it was called Laser Spine Institute. It was just a marketing gimmick. So clearly they understood the value of the laser, but they just never used it. Because the type of surgery we're doing right now with the laser, you really need to see the laser with your eyes. Like right now you can all see the laser, right? It's a blue fiber, and then in the center there's a piece of glass, and that's what transmits the energy. You can actually see it really well, and you can direct it visually. But you have to do endoscopic surgery to do that, and they weren't doing endoscopic surgery. They were doing open surgeries. So I have to admit, if you're going to do open surgery, this probably won't be that useful. But it's extremely useful in endoscopic surgery, specifically for this purpose of debridement of the annular tear, to get it to heal. It's absolutely essential. And there is no other tool available that does it. It's the only thing that works. And I've been doing it now 16 years, myself, on my patients, for 16 years. That's a piece of herniation, by the way, the blue stuff. So I'm 100% sure there's nothing better, there's nothing else that can substitute for this laser. And I've tried everything else. We have literally unlimited resources to buy any piece of equipment, and we've spent millions and millions of dollars on our equipment, but there is nothing better than the laser, otherwise we would have it. So I'm just talking about these naysayers about laser that really don't know anything about lasers because they've never really used it. So don't believe these people that say lasers are no good. Maybe lasers are no good with open back surgery. I agree with that. But even Dr. Pincus at UF in Gainesville, where I trained, is using it in open surgery for kids. But he was using a microscope too. And a microscope gives you a pretty good view of the laser, just like an endoscope. So I think it needs to be used in microscopic or endoscopic surgery to really benefit from it. But it's definitely used more and more now in neurosurgery. As a matter of fact, we're starting to use lasers in brain surgery, neurosurgery as well, for treating tumors and epilepsy. It's a laser interstitial therapy. It's a newer technology, and it can be done with minimally invasive treatment. So really the key about lasers is the minimal invasive nature, because you can deliver the laser energy through a 0.5 millimeter or a 1 millimeter fiber. This is a 1 millimeter fiber, but we also have 0.5 millimeter fiber. It's just half the diameter. And you can deliver more energy with this fiber, so it actually does the work faster, which is better for the patient. Because when you're doing with anesthesia on a patient, it's shorter is always better. The longer the patient's under anesthesia, the higher the risk of complication. So using a bigger fiber is always better, as long as it reduces the amount of time in the operating room. It gives an advantage to the patient, which this does. So, all right, let's go ahead and show the video of how the Deuk laser disc repair actually does its job, how it works. That's the tear right there we were talking about. See all that pink stuff? That's the inflammatory tissue from the tear. You're about to see how the Deuk laser disc repair works.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
For those of you who are familiar with a process called mining, if you're mining a precious metal like gold out of a rock, what you look for is what's called a vein of gold. And what you see is the actual gold inside the rock. And it's all in kind of like a line of gold, or a vein of gold they call it. The same thing here with the herniation. You can kind of see the blue vein right there. That is the herniation. And the white stuff here, a lot of it is scar tissue right there. It's turning a golden color. That is not normal. That's an indication of calcification of that tissue, which means it's abnormal. Should not have a calcified annulus. All right, we're just about done chasing this vein of blue. And again, the blue is the dye that we introduced into the nuclear material, and it stains degenerated nucleus pulposus. That's the bad stuff, the stuff we want to get rid of. All right, just about done. Another 10 seconds or so. Let me just take a quick peek. That's the epidural space. There's fat and some veins. Maybe just a little bit more right here, and then we'll be done. This is kind of abnormal tissue right here. This is all part of the annular debridement. If you don't debride the annulus and get rid of the herniation that's stuck in it, it won't heal properly. And so that's what we're trying to do, is get this to heal. Once it's healed, there won't be another herniation. All right, looks good to me. There's still a little bit right here. That's not normal. I'm going to zap this down a little because I think it's bulging out right where his nerve is. We want to get rid of these abnormal bulges. All right, that should be good. That's good. We debulked it. Okay. That looks pretty good. We're done at L3-4. And next we're going to move on to L4-5, which is the really hard one to do because it's so collapsed, and the way the bones have shifted, they've made it very hard to get inside that disc. One thing I would normally do is I would come from further lower, down lower, to get a better angle at getting into that area, but because the surgeon before put all this bone graft over here, they laid down bone graft for the fusion, and what that did was it grew into a big hard mass, which is impossible to get through. So I have to go above it or to the side of it. Going to the side of it's not an option, but going above it is, and that's what I did. But by coming from above, the angle of approach is not conducive to getting into that retrolisthesis section. So I've planted my needle at 4-5 right near the entrance of the disc herniation, and then I'm going to try to use a stiffer tool to get into the disc. Guys, there's some herniation right there. Just take it. You don't have to use that. All right, we're going to bring the fluoro in. Any questions from our audience? Because if there are, just ask me.
No current questions.
All right, great. So Deuk Spine Institute broadcasts surgery live, so you can all ask questions during the surgery, get clarification. Also, you're able to see exactly what's being done throughout the entire surgery. So we don't edit the surgeries. The reason we don't edit the surgeries is we want you to see what goes on. Sometimes we have struggles. We have issues, you know, and that's part of surgery, and we want the public to see that. We want people to see the truth when it comes to spine surgeries. So this is going to be a challenging time for me as a surgeon to get into this 4-5 disc. All right, let's get a shot. How's our blood pressure? Yeah. So it's okay, but it's just a little higher than we want it. So far, we've lost about 3 milliliters of blood, 3 cc's. Now, I'm going to show you something, folks. If this patient didn't have the Deuk laser disc repair, he would need to have a much bigger surgery.
Can we switch the line, please?
The surgery he would need would have to be a skin incision big enough. Can you see this here?
Yep.
That's big enough to go above the L3-4 disc and then go down to the fused area where he had it before. Just lay still. How's he doing? Good? Yeah. Yeah, this is going to be challenging, but let's see how he does. It's a lot of scar tissue. So this is probably a good 9 inches of a surgery incision. Lots of bleeding. And then, of course, he'd have to have screws and rods put in at 2 more discs, which he doesn't want. Nobody does. Honestly, I think that the original surgeon, could have fixed, the original surgeon could have fixed the L4-5 disc at the same time, but he didn't. And we see that a lot. Why does that happen, Sean? It happens because, unfortunately, surgeons either misdiagnose the patient and don't feel that the second herniation or disc needs to be fixed, which is wrong, or they want to bring the patient back for another surgery so they can make another surgery worth of money, which is horrible, but that happens so often I can't begin to tell you. Not here at Deuk Spine. We do everything in one surgery. But a lot of other spine surgeons will do multiple back surgeries on patients. As a matter of fact, we have one of the worst in the country just here in Brevard County, just south of us. He routinely does 4, 5, 6 fusion surgeries on people. I hear stories all the time how the waiting room is full of patients who have already had 3 or 4 fusions. They're back for their 5th and 6th one. That's been going on for years, but that's not unique to this area. That's pretty common all around the United States. So the reason why surgeons only do one level when they need to do 2 or 3 is there's a multiple reasons. One is they may not be comfortable doing multi-level fusions and take out the guide wire. And another reason is they honestly just may not have the time to do it. Sean? You know, there's always tea time at the golf club. You want to get your day done, but that's not in the best interest of the patient. So we're in. It worked out perfectly, just like I thought it would. And I've had to use that technique. That's the Deuk spine slide. The Deuk spine slide. Okay? And it's real, and it's important. And if you're a spine surgeon and you do endoscopic transforaminal lumbar surgery, you may someday have to do the slide. You won't get the needle in the disc, okay? And you got to do an outside-in approach, which we kind of did. All right. So for those of you who don't know, this is the tube that we do the surgery in. Why don't we, we've already run 2 videos, right? How do they get back pain from a herniated disc, and how the Deuk laser disc repair works, right?
Correct.
Let's show them a comparison of what it's like to have a fusion versus the Deuk laser disc repair. Because there's a lot of people out there that are told by their surgeon they need a fusion when they really don't need a fusion. Virtually none of them need a fusion. Now, your surgeon may not know how to do the Deuk laser disc repair, but that's their problem. Don't make their problem your problem. Don't settle for a highly invasive surgery with screws and rods when you don't need it. Okay? Stand up for yourself and go get better care. Right? Avoid doing a surgery that is worse for you just because that's all your surgeon knows how to do. I mean, some people are happy settling for that, but if you have a choice, avoid fusion. You can see the problems that it creates, adjacent segment disease. Everything okay? All right, we're in, and now we need to remove our dilator. Then we'll have a tube that we can do the surgery with. Great, nice job, Luis. Yeah, it's perfect. Great job. So you can see the dilator's out, the tube is still there, and now we're going to go in and clean out the tear and herniation that's basically causing the pain and symptoms from this particular disc, L4-5. Remember, we didn't do a discogram here because I didn't have the needle inside the disc. I couldn't get it in, but I was able to get the tube in because the patient's asleep, and I was able to kind of like use the dilator, which is thicker and heavier and stronger, to kind of get a better angle of approach. All right, hopefully you're enjoying the surgery, but let's cut to the DLDR versus lumbar fusion video. There's the tear, by the way, and the inflammation. Nice job, Dr. Berndes.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself, whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement, whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
No problem. Welcome back, everyone. Yeah, I'm looking at this going, it's so slow. We were just talking about Arius, my son, who is traveling today to Belgium. You got to push this way towards me. Yeah, there you go. And he's racing in the Italian F4 championship. And Luis and I were just reminiscing about there was a time, it was very funny. Arius was, I think, 9 years old, right? And he was racing go-karts at a competitive national level, like a national, almost a national champion, but not quite yet. He, of course, became one later, but several of my staff that worked for me, and Luis just reminded me of this, they said, oh, we could beat your son in go-karts. And I said, no, you can't. And they said, oh, yeah, there's no way a 9-year-old kid's going to drive faster than us. So it was just funny because we went to the track in Orlando, and they literally drove against Arius and go-karts. And Arius lapped them, literally lapped them, got behind them in 2 laps. That's how much faster he was. And he just sat behind them for like 5 or 6 laps. And I said, why did you just stop and not pass them? He said, I felt really bad for them, Dad. I didn't want to embarrass them. It's a 9-year-old kid. You were there, right, Luis? Were you there at that time?
No.
That was Kevin.
Yeah.
Remember Kevin? And I think it was like
That was Augusto.
an Augusto. Yeah, but Augusto knew. Augusto knew Arius could not be beaten by my staff. Augusto knew a little bit about Formula One racing and the skill and talent that these drivers have. It's not to be minimized. Anyway, it was funny because Arius really did give it to them. That was the last time they ever talked smack about being able to beat Arius in racing. We need about, it just depends. I'm trying to get the laser fiber where I need it. Maybe 5 more minutes. So to remind you all where we are at L4-5. This is the really bad disc. And oh, by the way, while you guys were watching the video comparison, something interesting happened. We had a big herniation that came out. Now, why is that interesting? Because when you look at this disc on the CAT scan and MRI, you're thinking to yourself, hey, Luis, I need help here. I got to get it to 12 o'clock. So I don't know what he's doing, but it's not really working. you look at the disc on the MRI and on the CAT scan, and basically you're thinking to yourself, there's no disc left. But there was definitely a big herniation, and I'm going to show it to you in just a minute. All right. So, any questions from our audience?
Yes. It's one from Sue on Facebook.
Hello, Sue on Facebook.
She said it's about the racing. And she's like, no way non-racing adults can compete against experienced child racers.
Right.
Did Dr. Deuk not fancy another trip into Europe? It's 30 degrees here now.
30 degrees, yeah, it's hot. Yeah, Sue, thanks for asking. We're heading to Belgium. Arius is racing at Spa this weekend. Spa-Francorchamps, for those of you who follow Formula One. Arius is not in Formula One, he's in Formula 4, number 4. And that is the first step to Formula One. But he's being a total teenager, driving me crazy, my wife crazy. He just literally wants to just be with his girlfriend 24/7. And of course, it's his first serious girlfriend. So I remember those days. It's very easy to get distracted. That said, he's going to be racing in Spa for the United States this weekend, and then the next weekend he'll be racing in a place called Zandvoort, which is the Formula One racetrack in Holland. Yep, and then he's going to be racing outside of Rome, Italy, in a place called Vallelunga, which is the Formula One track right outside of Rome. So we got 3 weekends in a row of Italian and German F4. You can go to the Italian F4 online and you can see live stream and watch him race. So there is the disc at L4-5. See how collapsed it is, but we've gotten rid of the herniation. So we're pretty much done. I'm going to pull the tube out, and I want to show you guys the herniation that came out of this. I mean, literally you wouldn't think there's a herniation because the disc is so collapsed and degenerated, but there's definitely a herniation there. I'm going to use a little antiseptic called betadine. Once the betadine goes in, we'll flush it out for a few flushes. Everything okay? Crystal? Everything okay? Yeah. Yep. Wait. What's the brand of stimulator? No, seriously, Dr. Patel may have a controller. I would go talk to Patel. We put spinal cord stimulators in. So we have to be able to turn them off. All right, so this, folks, if you haven't seen this already, and there's a little piece of disc herniation right there, but this is what we did the whole surgery through, okay? So I'm going to take this out and put a little bit of pressure. I always do for about a few minutes in case there's any venous bleeding. We lost about 5 milliliters of blood. Just so you understand how much a milliliter is, 20 little drops of blood. Guys should be bringing me that herniation. 20 drops of blood is 1 mil. So we probably lost 5 times 20 or 100 drops of blood. So check this out. Thank you, Luis. This is the herniation that came out. Can you guys see this?
Yeah.
Yeah, and of course we used a grabber to pull it out, and I'll show you, because I think you guys were watching a video at the time when we got this. But yeah, I literally grabbed the herniation out with the grabber and pulled it out. There came out in 2 big pieces at L4-5. So he's going to be feeling a whole lot better. Now, all that was done with this tiny little 7 millimeter incision. Pretty cool, huh? No open back surgery. Good job, everybody. Great job. Remember, no opsite or tegaderm, okay? Any questions you have for me, type them up. And if you don't know about our app, Duke Spine Institute has a free spine app on iPhone and Android. So feel free to download the app because it is free and it has some good information. By the way, everyone heard that Tesla has a phone coming out? I didn't hear that. I wonder if it's an Android platform. Anybody know? Yeah, I heard about that. It certainly isn't an iPhone, iOS platform. All right, type your questions up and I'll come answer them for you in a few minutes. Why don't you go ahead and cut to the testimonial you put together yesterday if you have it available. It's Dr. Deuk at the Duke Spine Institute here in Florida with one of my patients who had the Deuk laser disc repair for a back injury, and it was around 6 to 8 weeks ago. And you're back for a checkup. How are you feeling today?
I feel wonderful. I feel great. I feel fantastic. I mean, this is the man. He's the man.
Well,
and I came in with a lot of pain. I couldn't believe it. And now I'm virtually pain-free. It's unbelievable.
How long did you have your back pain? How did that start?
Oh God, that happened many years ago at work, at least 20 plus years. And I had other surgeries in the past, and they really didn't help. And this last one, it just got so bad that I had to do something. So luckily, through the grace of God, I came here, and
Amen.
Yeah, and I'm A1 now.
Awesome. So you had your surgery. You've been doing therapy. Would you say the pain you had in your back before surgery is still there, or is it gone?
Oh, it's gone. It's gone. I have little twinges now, but they're muscular, and which is fine. That's going to go away over time. But my God, what a relief! I'm ready to get back out there and do all the things I used to do, man. It's kind of exciting. It's kind of fun.
Well, it's important that people understand too. When you have 20 years of chronic debilitating back pain, what happens is the muscles in your back shrivel up and atrophy because you're really not active anymore because it hurts too much. So, you know, we can fix the spine pain, but it's going to take time to rehabilitate the muscles and get them back to normal. So I'm glad we're touching on that. So what does your life look like now that we've gotten rid of your back and leg pain?
Well, yeah, I'm going to go back to what I've always done and what I've always enjoyed doing, which is my automotive hobby. And I'm really looking forward to being able to actually lift things again and getting the contorted angles that I used to get working under cars and stuff. It's just gonna be nice. Quality of life is it's
not too soon with any of that lifting engines.
All right, yeah, all right. But I have, all kidding aside, I have noticed over the years I developed a way to walk, almost a crab walk kind of thing, and I got used to it, and I got, well, that's the way it's going to be. I don't have that now. I mean, it took a little while because it was some pain trying to get the muscles to come back. But my God, you just stick with it. If you got to get it done, stick with it, because you're going to get better. You're going to get better.
Well, yeah. Congratulations. Is there anything you want to say to wrap things up to your audience?
He's the man. Come see this guy.
All right, congratulations.
Thank you, doctor.
You're
God
welcome,
bless.
Sir. God bless you. All right, so now you've had the surgery. How are you doing today?
I feel awesome. I mean, the only pain is, surgery site pain, and that's it. No nerve pain.
So the pain that you had before the surgery is
gone.
Gone, cured.
Gone. Yeah.
Awesome.
Yes, that's amazing.
I'm Dr. Deuk with the Duke Spine Institute, and I'm here with one of my patients who just had the Deuk laser disc repair on her lower back, and she wants to share her story with you. Now, you came to Duke Spine Institute because you were having back and left leg pain for how long?
Well, the terrible left leg pain, probably about 2 years, but prior, I've had issues since I was 14 years old. So it's been a lot of roller coaster pain since then.
So you've had back pain since you were 14. You're clearly not 14 anymore.
No.
And so that's like 15, 20 years, right?
Yeah, too long.
And so why didn't you get it fixed sooner?
Well, the doctors when I was younger didn't want to operate. They wanted to, I was young. They didn't want to take a chance because all the surgeries then at that point, there was just nothing there that wasn't going to be traumatic to my back and my spine. So I went through physical therapy, shots, decompression. They did that and nothing was really working. And then it eventually kind of got better, and then it would get worse and it would get better, and it was just up and down, up and down.
Up and down. And the reason it got better was the inflammation from the injury to your disc started to get better.
Yeah.
But then you'd have another herniation with activity, and then it made it worse. So
Yeah.
when we were in there, and you can see from this video right here that we were pulling out lots of big fragments of disc herniation. You probably over your lifetime from 14 until now had at least 10, 20 different episodes of herniation, and that's what we saw when we were inside there.
Mm-hmm.
All right, so now you've had the surgery. How are you doing today?
I feel awesome. I mean, the only pain is, surgery site pain, and that's it. No nerve pain.
So the pain that you had before the surgery is
Gone.
cured.
Gone. Yeah.
Awesome.
Yes, that's amazing.
Now, you're not from Florida.
No, I'm from Ohio.
So you traveled from Ohio to the Deuk Spine Institute in Florida. Why did you come all the way down to Florida?
There was nobody near us or anywhere near us that had any other option besides either getting a discectomy or a laminectomy or a fusion. There was just nobody was doing anything else. And I knew I didn't want to do that again because I'd already had that done. So it didn't work. And
Didn't work.
I had a really amazing physical therapist that connected me with you, and the rest is history.
Yeah, your physical therapist found us and was intrigued with the surgeries we're doing here
Yeah.
and sent you here. So what are you going to tell your physical therapist? I call him Dr. Salinas. What are you going to tell him when you...
Oh man, I mean, I've already told him. I texted him the minute I got back to our Airbnb. I said, I feel amazing, and I can't wait to tell all the rest of the patients in our Facebook group, like, this works. So
It does. The Deuk laser disc repair really does work. Well, is there anything else you want to say to your fans out there or friends?
my fans and my friends, thank you for praying. Thank you for believing me. I think that's one of the biggest things. There's a stigma around back pain because you can't see it, that people are just faking it, or maybe they're babies. Like, why can't you just deal with the pain? And it overwhelms you. And so to come someplace that believes me and then fixes the problem, and now I'm sitting here and I can be like a fully active mom. So I'm just beyond thankful. Thank you.
Yeah, chronic pain robs people of their dignity and their happiness and joy in life, and also their loved ones, the people that care about them.
Yeah.
Because they suffer with you.
Yeah.
Yeah.
A lot.
Well, congratulations and praise God.
Yes.
You found us.
Thank you very much.
And I think you're going to do fantastic.
I'm looking forward to being strong again.
Awesome. All right. I'm Dr. Deuk here at the Deuk Spine Institute with one of my patients who's traveled from North Carolina because he had some herniated discs in his lower back and he was having problems with the back. What kind of problems brought you to Deuk Spine Institute?
Dr. Deuk, it was severe pain that I had never experienced before, and pain that scared me so much that I thought it was going to change the way I lived. I've got a family and I'm active, and it literally scared me to death. And as I'm talking to you right now, the hair standing up on my neck, the pain that I was suffering and where I thought I was, I didn't think there was going to be an answer.
And you were pretty much bedridden. You couldn't get out of bed. I remember you showed up here in a wheelchair because any standing was causing sciatic type pain in your leg.
Yeah, there was no doubt. And that's not an over exaggeration, where I could maybe get up, stand for 15, 20 seconds so I could get to the bathroom to go urinate, for instance. But then when I got there, I had to lay on the floor so I could rest up a little bit so I could stand with pain to even be able to try to urinate. And this went on for 2.5 weeks. It was absolutely brutal. And there was no respite. Pain that I had in the past, I could find some position where there was some respite from the pain, and there was nothing.
So your wife is a physician. Was she able to fix your back problem for you?
I wish. No. I mean, she, you know, she consoled me. And in the town that we come from, we know a lot of folks. And to be absolutely honest, we just weren't getting a lot of help. And like I said, we know a lot of folks, and it was prolonged, and we were talking about pain management and all that, and that's just not for me. And like I said, I was scared to death.
The problem with pain management, unfortunately, is that it doesn't fix the issue when you have a herniated disc and back pain from a herniated disc, because you need surgery on that disc to repair it. That's what the Deuk laser disc repair did. And you can actually see here that we went into his disc with the endoscope and we were cleaning out the herniation with the laser. And the laser actually makes a huge difference. People say, oh, lasers, they're not used in spine surgery, but they are. And they're very, very powerful tools and very precise. So we were able to clean out your discs, remove the herniation. And how do you feel today?
I feel great. I mean, it's probably, I mean, I know I'm on camera right here, but I literally could not walk into the office yesterday. And I'll just, I mean, you're gonna see my shorts and everything, you'll have to edit, whatever, but I'm able to walk.
That's awesome.
And I'm just, it wasn't even close. I was actually, and I don't know if you can tell from the camera that what my personality is, but I try to be very polite, and I was apologizing for profusely sweating because I hurt so bad. It's not because of the Florida heat by any means, it's because I hurt so bad. I'd never experienced pain like that. And like I said, there's no
because
restaurant.
you're a redneck too, you know, you're not that far from Florida.
That's
you're
right.
Just up a state or two, right?
That's right, yeah.
A couple of states. So you're feeling better today. It's been less than 24 hours since
Yep.
we did your surgery. You went home an hour after the surgery, back to your hotel with your
Yep.
lovely family who I met.
Yep.
And how do they feel about your progress?
They're happy that I'm happy. You know what I mean? Because they were scared too. You know, now they were putting on a strong front, but I am just telling you, I was at my wit's end. And I certainly are a lot more appreciative of people who have pain that I'm aware of, because when there's no rest from it, oh my gosh, you know what I mean? I was really at my wit's end, and you saved me. So I appreciate you very much.
You are welcome, sir.
Yeah.
Is there anything else you want to say to your fans out there?
Thank you. Sorry, I could have prettied you up for you a little bit better. So just had surgery yesterday.
All right.
Cut me some slack.
Excellent. And you're heading back home today, correct?
Yeah, right, going back on the plane later this evening. The kids are going to swim a little bit down here in Melbourne. I'm just going to rest and watch TV, but then we're going to get on a plane a little bit.
Awesome.
Yeah.
All right. Well, congratulations. You had faith.
Yes.
Took the
I have
leap
faith.
and you got the surgery done.
Yes, sir.
All right. Awesome.
Yep.
Hello, I'm Dr. Ara Deuk-Majan at the Deuk Spine Institute. You've just watched a live stream surgery on the lumbar spine or lower back for a patient with back pain and left leg pain. This patient had a fusion already at L5-S1 done by a doctor, not me, but some other doctor. The fusion looked solid. I didn't see any problems with it. There was no hardware loosening or broken hardware. The bones were solidly fused. The problem really was what's called adjacent segment disease. Adjacent segment disease. We're going to tag the video with adjacent segment disease so that it gets seen by people. But that's the problem with fusion. When you don't do a fusion at all the levels that are affected, then you fuse only one or two, then the ones above and below are going to end up becoming more painful. You can see the fusion here with screws and rods. But basically, you're taking movement away from someone's spine. The spine was meant to move. That's why God put joints in the spine, so you can bend side to side, forward, backward, and even a little bit of rotation. So all three axes of rotation, we call it, you're able to move. And when you start doing unnatural things to the spine, like putting in screws, rods, fusing, of course you're going to end up changing what's called the biomechanics of the spine. Biomechanics means the movement of a biological organism, the organism obviously being a human. So when you alter the biomechanics or shift the biomechanics of the lumbar spine, you're going to start to get stresses on other joints nearby that the closer those joints are to the fusion, the more affected they will be. And this patient came back to us and he didn't want another fusion. He had that done by another surgeon. He didn't want another fusion. He wanted the endoscopic laser surgery. He didn't want fusion because he didn't want to have to keep dealing with this problem over and over again. And so every time people get fused, it creates stress, more stress on the joints above and below the fusion, causes those joints to wear out quicker. We call that adjacent segment disease. It happens around 20% of patients with fusions. It's probably more like 50% when it's not, the surgery isn't done right the first time. There's a lot of surgeons that don't do the surgery right. Okay, of 100 spinal fusions done, probably 90 out of 100 are done wrong in such a way that it's going to create problems for the patient. That's why there are so many people out there, millions, with surgeries and back pain, neck pain as a result of the fusions. I'm talking on a global scale. In the United States alone, there's probably millions of people with adjacent segment disease, and they're suffering. They've had the fusion done, they've had the artificial disc done, they're in pain, and the reason is not necessarily at the level that's fused, it's the level above or below, remote, or even muscles and joints near the fusion, like the SI joint, the piriformis muscles, they get injured. So folks, stop fusing. The Deuk laser disc repair, the surgery you just watched, is the future of spine surgery. 95% of spine surgery is done for degenerative conditions. The Deuk laser disc repair is the solution to degenerative spine conditions like herniated disc, degenerated disc, ruptured disc. So if you know somebody with back or neck pain, they're probably suffering from a disc problem. This surgery, the endoscopic surgery you just watched, is the way to fix them. It's the least invasive and most successful surgery. There is virtually no blood loss, and there's no downtime. These people are back on their feet the next day, going back to a normal life. They just have some mild restrictions with lifting and bending. Okay? The success rate of this surgery is 98% elimination of back pain, 98% elimination of leg symptoms from the disc herniation. Of course, if they have a different problem, like a fracture somewhere else, that's not going to fix that problem. But most people with back and neck pain, it's coming from a disc problem. Herniated disc, bulging disc, ruptured disc, slip disc, extruded disc, protruded disc. There's lots of disc terms, but they're all the same. Basically, it's a disc injury causing symptoms. All right, hope you enjoyed the surgery. We'll be back. Actually, we won't be back. We're going to be doing a new type of rhizotomy, which the Deuk Spine Institute has pioneered. It's called the Deuk plasma rhizotomy. We're not quite ready to show the world this procedure. We're still doing it covertly without broadcasting it. So someday we'll be able to show the technology to you. But it will be a patented treatment, and we want to make sure we get all the patent applications in place first. All right, have a wonderful day, and we'll be back on Thursday.